Good morning, all student. Today my lecture is about pneumonia. The previous lecture by Dr. Sumaya, she was speak about the bacteriological aspect of pneumonia and tuberculosis. In my lecture, I concentrate on the pathology, pathogenesis, clinical picture, diagnosis, and treatment of the pneumonia and tuberculosis. Before starting lecture, we have some objective learning. First, what is pneumonia? Second, classification of pneumonia. Third, predisposing factor to the pneumonia. Only I mentioned the causative microorganism. The clinical picture of pneumonia. Pathology of pneumonia. And also how to assess the severity of pneumonia. Then to go to the investigation and diagnosis, the treatment and complication. So what is pneumonia? As we know, pneumonia, it means inflammation of the lung parenchyma, but it is acute condition. So it is acute infection of the lung parenchyma. Lung parenchyma, it means the lung alveoli and interstitial tissue. So mainly it is in the lung alveoli. So it is acute infection of the lung parenchyma or acute inflammation of the lung parenchyma associated with recently developed radiological pulmonary shadows. Recently developed radiological pulmonary shadow, which this shadow may be segmental, lobar, or multilobular, and affecting segment of the lung, the lobe of the lung, or may affecting multilobe or multilobular of both lung, and caused by a different microorganism. Different microorganism, it means either is bacteria, different bacteria, or could be viral, or could be fungal, or could be others. So the definition is acute infection of the lung parenchyma associated with the recently developed radiological pulmonary shadowing, which may be segmental, lobar, multilobular, which caused by different microorganisms. Pneumonia, as I mentioned, is inflammation or infection of the gas exchange region of the lung parenchyma, which involving the alveoli. Pneumonitis is different. Pneumonia is infection of the lung parenchyma by microorganism, by bacteria, viral, but pneumonitis is inflammation of the lung due to the other cause other than the bacteria, either physical or chemical damage, like chemical pneumonitis, radiation pneumonitis. So it's different from the pneumonia, which is due to the infection by microorganism. So pneumonia is infection of the lung parenchyma by microorganism, but pneumonitis is inflammation of the lung parenchyma by other microorganism, not by microorganism, by the physical or chemical damage. For classification of pneumonia, they classified according to where it happened. So the commonest one is community-acquired pneumonia. Community-acquired pneumonia يعني pneumonia occur outside the hospital, occur in the community outside the hospital. The hospital-acquired pneumonia, or called nosocomial pneumonia, this occur in the hospital when the patient is admitted to the hospital and then develop pneumonia. This is called hospital-acquired pneumonia. Could be occur in the general ward, or could be occur in intensive care, or could be occur when the patient is on the ventilator. This is called nosocomial or hospital-acquired pneumonia. Pneumonia in the immunocompromised hosts. Patients who are immunocompromised, like patients with malignancy or patients receiving the immunosuppressive drug or patient with the diabetes mellitus and other. And if the patient has immunocompromised when they develop pneumonia, why we put this term in separate? Because depend on which type of microorganism causing pneumonia in the community, which microorganism causing pneumonia in the hospital, or which microorganism causing pneumonia in the patient who is immunocompromised. And the last one, which is suppurative and aspiration pneumonia. And pneumonia occurs due to aspiration with the oropharyngeal secretion, and this may lead to the suppurative pneumonia develop localized pus or multiple abscess or localized abscess. We come to each of them separately. Other classification is morphological or anatomical classification. Lobar pneumonia and bronchopneumonia. Lobar pneumonia is a radiological and pathological term. Radiological and pathological term, referring to the homogeneous consolidation of one or more lung lobe, often with associated pleural inflammation. It means there is the homogeneous consolidation or opacity in the X-ray of one lobe or more lung lobe, and this usually lobar pneumonia associated with extent to the pleura, causing pleurisy and pleural effusion, associated with the pleural inflammation. The bronchopneumonia, this means bronchopneumonia, and affecting the pneumonia and the bronchus. So it is patchy alveolar consolidation. Patchy alveolar consolidation affecting, associated with the bronchial and the bronchial inflammation, often affecting the both lower lobes. Lobar pneumonia will affecting one lobe or more than one lobe of the lung, associated with the pleural inflammation. Usually this is caused by the pneumococcal pneumonia, or sometimes by other like Klebsiella pneumonia or other. Bronchopneumonia, there is not affecting the lobe. There is patchy alveolar consolidation associated with the bronchial and bronchial inflammation, often affecting the both lung or one lung, mainly affecting the lower lobe. And this occurs in patients with hemophilia influenzae, or caused by the viral infection, or sometimes by the atypical pneumonia, like mycoplasma and other. This is a diagram you see. This is a lobar pneumonia. You see here, this pneumonia affecting this lobe. This is a lobar pneumonia. Usually here, there is the pleural inflammation, and usually caused by the pneumococcal pneumonia. The other, it is patchy. You see here is patchy consolidation, not as uniform, and appear in the X-ray as non-homogeneous opacity or hazy opacity. But the lobar pneumonia appeared as the homogeneous opacity of the lung. We come to the community-acquired pneumonia. What is the community-acquired pneumonia? It's infection of the lung parenchyma in a person who is not hospitalized or not living in the long-term care facility for more than 2 weeks. And patient or person develop pneumonia or infection of the lung parenchyma who is not hospitalized for more than 2 weeks or not living in a long-term care facility. Long-term care facility, it means those يعني in the some center which dealing with the center of the tuberculosis or center for dialysis or other center يعني this is long-term care facility. So infection of the lung parenchyma in person who is not hospitalized or not living in the long-term care facility for more than 2 weeks. CAP يعني community acquired pneumonia usually spread by the droplet infection or by airborne. Droplet airborne or droplet infection يعني via inhalation of the droplet, and most cases occur in the previously healthy individual. Community acquired pneumonia only occur in the previously healthy individual. The incidence is 5 to 10 per 1,000 adults suffer from the community acquired pneumonia each year. And for each 1,000 people, 5 to 10 adults may suffer from the community acquired pneumonia yearly. Most patients may be safely managed at home. 20 to 40% may need hospital admission. 5 to 10% of those require intensive care. So, for treatment of the community acquired pneumonia, about 60 to 80% they managed at home. 20 to 40 may need admission to the hospital. From these, 5 to 10% may need intensive therapy or intensive care. And death rate from the pneumonia usually is low, it's 5 to 10%, and sometimes less than 5% with a new antibiotic. But in those cases who have severe illness, like patient with malignancy, patient with COPD, patient with diabetes mellitus, sometimes, and those occur with severe microorganism, necrotizing pneumonia, the death rate may reach 50%. There are some predisposing factors to the pneumonia. So not all patients develop pneumonia. Those patients who have some of these predisposing factors are more liable to develop pneumonia. We can because there are many defense mechanisms in the respiratory tract against the infection. We mentioned it in the previous lecture. So one of them, we come to the cough reflex. Cough reflex is one of the protective mechanisms against chest infection. When there is loss of the cough reflex, patient may be able to develop infection or pneumonia. Loss of the cough reflex occur like patient when he is comatose due to any causes. Drug poisoning, alcohol poisoning, after CVI, maybe coma after other metabolic condition. So when the patient is comatose, there is loss of the cough reflex and there is inhalation of the oropharyngeal secretion may lead to the pneumonia. Other anesthesia, patient has anesthesia also become comatose because of the drug and where there is loss of the cough reflex. Or patient with a neuromuscular disease like myasthenia gravis, myopathy, and other also. Here there is also loss of the cough reflex. So loss of cough reflex is one of the important mechanism which is act as the protective defense for the infection. When the loss of the cough reflex may lead to the or predispose to the pneumonia. The second is injury to the mucociliary apparatus. As you know, the epithelium which lining the respiratory tract is the other color epithelium or the squamous epithelium, and these contain the cilia, and these cilia are moved by this movement. They expel the microorganism and other foreign bodies also. So when this mucociliary apparatus is injured, so the defense mechanism against the infection will become lost. And this injury to the mucociliary apparatus occur mainly by cigarette smoking, viral infection, and there is continued infection like the upper respiratory viral infection, coronavirus, and other. And there is a condition called immotile cilia syndrome. This is a congenital condition in which the cilia become not moved, and this patient may develop other syndrome like Cartagena syndrome, may develop sinusitis, bronchiectasis also, and even may develop infertility. Immotile cilia syndrome, this is a congenital condition, and those patients are liable to develop recurrent chest infection. So the second, due to the injury to the mucociliary apparatus. The third mechanism or disposing factor is inhibition of the phagocytic activity in the lung. In the lung, there is phagocytic activity. Usually, it's caused by the alveolar macrophage. When any microorganism or any foreign body entering the lung or parenchyma, the macrophage or alveolar macrophage can engulf or attack this microorganism. So when this phagocytic activity is inhibited by the alcohol, or by diabetes mellitus, or by immunosuppressive drug, or by other disease like the malignancy, leukemia, lymphoma, all this inhibit the phagocytic activity in the lung and may lead to the recurrent chest infection. The other is pulmonary congestion, with congestion of the alveoli. When the alveoli are filled with the exudate, with the blood, or with the fluid, this may occur in the left ventricular heart failure. So these patients are liable to develop pneumonia. And in such a case, when we treat the heart failure, and there is no response, and the heart failure become more deteriorated. Why? Because of the infection. So we should treat pneumonia and also treating the heart failure. The other is stasis of the lung secretion. And when the lung when there is secretion inside the bronchioles, and this secretion sometimes become increased or become very vivid, was difficult to expectorate. This also is the site of infection. Mainly this occur in the cystic fibrosis or also occur in the bronchiectasis. So these are the main predisposing factor for the pneumonia or for the chest infection, which loss of the cough reflexes, injury to the mucociliary apparatus, inhibition of the phagocytic activity in the lung, pulmonary congestion, and stasis of the lung secretion. We come to the causative microorganism of the community-acquired pneumonia. As I mentioned, there are many bacteria causing it, but the commonest one and the majority of the cases are due to the Streptococcus pneumonia or called Streptococcus pneumonia or called pneumococcus. The majority of the cases caused by Streptococcus pneumonia, about 60 to 70% of the cases of the community-acquired pneumonia caused by the Streptococcus pneumoniae or pneumococcus. These are gram-positive cocci present in the pairs, called diplococcus, gram-positive diplococcus. The other microorganisms are Mycoplasma pneumoniae, Chlamydia pneumoniae. These are common in young adults. Mycoplasma pneumoniae, this can cause atypical pneumonia. I'll come to it later on. Other microorganisms, Haemophilus influenza, should be considered in the elderly patients, especially those patients who have COPD, chronic obstructive pulmonary disease, usually caused by the pneumonia in the patient with COPD, mainly caused by the Haemophilus influenza. In younger children, we put the viral infection as the first term. Viral infection predominant. There are many viruses, respiratory syncytial virus, adenovirus, coronavirus. There are many influenza virus. Many viruses can affecting the young children, and pneumonia in the young children mainly due to the viral infection. A history of the foreign travel might suggest Legionella infection or Legionella disease. Legionella pneumophila also is atypical microorganism causing atypical pneumonia. Patient who has flu-like illness or influenza, the secondary bacterial infection usually caused by the Staph aureus. So the cause of the post-influenza pneumonia usually is caused by the Staph aureus. Why called atypical pneumonia? It is a common. It accounts for the 20% of the community-acquired pneumonia. So after the pneumococcus, or after the streptococcus pneumonia, the second cause is the atypical pneumonia, which is mainly caused by the Mycoplasma, which is the most common, Chlamydia, and Legionella pneumophila. So atypical pneumonia caused by Mycoplasma, Chlamydia, and Legionella pneumophila. Why it was atypical? Because it has atypical clinical presentation. It causes very severe symptoms like very high fever, myalgia, and patient may develop other extrapulmonary manifestation, may develop myocarditis, may develop hemolytic anemia, may develop neurological manifestation like the meningitis, CVI also, and there is the association between the clinical feature and the examination. And patient may have very severe high fever, cough, usually the dry cough, and examination of the lung may be normal or there is some fine crackles. So what is called atypical pneumonia. And the microorganism also is atypical. These microorganisms are not cultured by routine culture. For diagnosis, it needs a serological diagnosis, detection of the antigen and antibody in the blood and the urine. We come to pathology of pneumonia. As mentioned, the commonest type of chronic acquired pneumonia is the pneumococcal pneumonia or pneumonia which is caused by the streptococcus pneumonia. Usually it is called lobar pneumonia, and the pathological hallmark of the pneumonia is consolidation. What is consolidation? Consolidation is the result of the replacement of the air in the alveoli by transudate. Replacement of the air in the alveoli by transudate, pus, blood, cell, or other substance. And normally, the alveoli are filled with the air. But patients when develop infection and consolidation, it means these alveoli are filled either with the exudate, with the pus, with the blood, or with the inflammatory cell also. Consolidation, it means solidification of the lung parenchyma. And this consolidation has 4 stages. Stage 1 causes congestion, and only there is congestion of the capillaries and blood vessels surrounding the alveoli. Still, there is no fluid inside alveoli, or there is congestion in the blood vessels surrounding alveoli. Then called reticulization. Here, when the fluid are passed to the side alveoli and contain many RBC, so give the picture of the liver. Why called reticulization? Red because it contains many amount of the RBC. Then gray hepatization also become like liver, but the change become gray. Why? Because there is more white BC infiltrating the alveoli. So changing its color from the red to the gray hepatization. And the last, there is resolution. When this RBC and the white BC become either ruptured or become phagocytized by the other cell, then we start resolution of the congestion. And resolution, usually this condition may need time. It takes about from 1 week to 3 weeks also. And in resolution, there is no or little scarring. So consolidation is the replacement of the alveoli by the transudate, exudate, pus, blood, inflammatory cell. And the stage of the consolidation are first congestion, second reticulization, third reticulization, and the fourth resolution. This is a diagram. You see this is the trachea, and this is the infected lung. If you take this is the alveoli, there is thickening of the alveolar wall due to the congestion, and also there is accumulation of the mucus, transudate, exudate, and the cell inside the alveoli. And later on, this was filled by the inflammatory cell and even pus is called the consolidation. Then you come to the clinical feature of pneumonia. As I mentioned, pneumonia is acute inflammation of the lung parenchyma. This acute inflammation, which is caused by infection mainly, it leads to the systemic manifestation, which is mainly patient develop fever. The fever or pyrexia, and this fever may reach to a very high degree, maybe sometimes reach 35.5 centigrade or even more than 40 centigrade. And the patient here may develop rigor, shivering, vomiting, and even may be confused because it is high fever. So the first manifestation is very high fever, 39.5 to 40.5. And in children, they may develop the febrile convulsion. The elderly patient may develop confusion state. And the patient become confused, he don't know the time, and it is confused or disoriented for the time, for the place, and even may develop difficulty in speaking or slurred speech. This fever may lead to the tachypnea, the increased respiratory rate, this tachycardia, this is the heart rate, and also there may be decreasing in the blood pressure or hypotension. The second feature are cough. When the patient develops infection of the alveoli, the patient will start to develop cough. And this cough is painful and dry first. But later on, when the alveoli are filled with the pus cell or filled with the inflammatory cell, they develop sputum. This sputum is the mucopurulent sputum, and sputum which contains the mucus and become purulent in color, right? Because of the bacterial infection. So mucopurulent sputum, or sometimes the sputum become rusty color sputum. Rusty color, it is like the يعني وكأخيها تقريبا وصل وكهارية. Rusty color occur when patient develop rupture of the RBC inside the alveoli. RBC are ruptured and give the sputum this color, rusty color, or even the patient may develop hemoptysis, and patient may develop cough with the sputum which containing blood, streak of blood. So cough first was painful dry, then develop the cough with the mucopurulent sputum, even with the hemoptysis or rust color sputum. Usually this occurs in the pneumococcal pneumonia. The other feature, as I mentioned, produce chest pain, and a lobar pneumonia may involve the pleura, and usually alveoli is insensitive to the pain, but when the alveoli, when the pleura is involved, develop the pleuritic chest pain. This chest pain is the sharp localized pain. It's increased by the deep breathing and by the coughing, and this pain may be referred to the shoulder or to the anterior abdominal wall, depending on the site of the pneumonia. If the patient has basal pneumonia, pneumonia at the base of lung, the pain may refer to the shoulder, is transport via the phrenic nerve or to the abdominal anterior abdominal wall, and sometimes may mimic acute abdomen. And many patients come with the acute upper abdominal pain, with sweat with a cough fever. This usually leads to the pleuritic chest pain, which is transmitted to the abdomen. The patient also may develop shortness of breath, and due to the hypoxia, may develop cyanosis also. As I mentioned, upper abdominal pain, tenderness in patients with a lower lobar pneumonia may develop. A patient with a lower lobar pneumonia or basal pneumonia may develop pain in the base of the lung, and this is referred to the upper abdomen. And this is confused with the acute abdomen, may be confused with the cholecystitis or other. So clinical features start with the systemic feature, which is mainly fever, rigor, vomiting, and this may lead to the tachypnea and tachycardia and hypotension. Cough which is first dry and painful, then become expectorate with the mucopurulent sputum. Sputum may be rusty colored, or there may be hemoptysis also. Pleuritic chest pain, which mainly occur in the lower pneumonia, and this space is localized pain increased by the coughing and deep breathing. There is shortness of breath and cyanosis, and patients with the basal pneumonia may present with the acute upper abdominal pain. And it's the diagram of the symptoms of the pneumonia. The main symptoms of pneumonia are high fevers with chill. In the lung, patient will develop cough with sputum, shortness of breath, pleuritic chest pain. Patient may develop fatigue, aches, generalized aches. Patient may develop headache, loss of appetite. There is low blood pressure, tachycardia, tachypnea, also nausea, vomiting. All these are a feature of the pneumonia. We come to the clinical physical sign of patient with pneumonia. Patient with pneumonia, because of the high fever, he is ill, he is toxic sometimes, and there is an increase in the respiratory rate. The temperature may reach very high, I mentioned 39 to the 40. There is an increase in the heart rate, respiratory and rate and heart rate also, and there may be hypotension. On examination of the chest, there is sign of the consolidation. Sign of the consolidation when you examine the chest by the inspection, palpation, percussion, auscultation. Inspection may be normal, but by the palpation, there is an increase in the vocal firmness over the area affected. Percussion is dull over the affected area. And by auscultation, first there is bronchial breathing because there is solidification of the lung. And here there is the broncholar become near the surface and they transmit the sound from bronchial to the surface. This is called bronchial breathing. But later on, when there is a resolution of the consolidation, the patient may develop crepitation. So in the consolidation, inspection may be normal. Palpation, there is increase in the vocal firmness. Percussion is the percussion note, and auscultation. First there is a bronchial breathing, later on there is crepitation. And even there may be a pleural rap also when there is extension to the pleura. Pleural rap. A patient with a bronchial pneumonia, here there is no consolidation. There is scattered crepitation, scattered crackles or crepitation in the both lung. Or patient may develop with a sign of the complication. The most common complication which occur in the pneumonia, as you know, is a pleurisy, pleurofusion, lung collapse, and this infection may lead to the lung abscess also. After we do the clinical diagnosis, we can assess the severity of the pneumonia. For assessing the severity of pneumonia, usually depend on the clinical feature mainly. We come to the term called CARB 65 score. CARB 65 score. What is the CARB 65 score? C, it means the mental confusion. See, I mean confusion. You notice the confusion. Patient will develop confusion, and disorientation. He don't know the person. He don't know the surrounding. He don't know the place. He don't know the time. This it means confusion. لخبطة. C, confusion. U, it means blood urea. Blood urea more than 7 millimole per liter. And I think it's equal to the 40 milligram per deciliter. R is respiratory rate. Respiratory rate is more than 30 beats per minute. It means there is tachypnea. And B is the blood pressure. Usually patient may be hypotensive, less than 90 over 60, also a bad sign, and 65, each more than 65 years. So there are 4 points in the CARB 65: confusion, blood urea more than 7 millimole or 40 milligram per deciliter, respiratory rate more than 30 cycles per minute, and the blood pressure less than 90 over 60, hypotensive, and the age is more than 65 years. If two of these present, this indication for the hospital admission. And patient with confusion with the tachypnea, or patient with confusion with hypotension. So if these two present, the patient may need admission to the hospital. If more high score present, and 4 to 5, and if all this present or 4 of this present, the patient may need intensive care unit treatment. Here this is the CARB 65, it is simplified in a diagram. As with confusion, blood urea nitrogen more than 35, respiratory rate more than 30, blood pressure less than 90/60, and age more than 65 years. We come from the score are from 0 to the 5. From 0 or 1, يعني there is no score or 1, the patient can be treated at home. 2 score of this, the patient needs hospital admission. 3 score, the patient may need admission in the medical ward. 4 or 5 score, the patient needs the treatment in intensive care unit because this patient carry high mortality rate. Later on, we come to the diagnosis of pneumonia. Diagnosis mainly depend on the clinical picture, then the investigation. In the pneumonia, we have 3 diagnoses. Clinical diagnosis, depending on the symptom and sign. Radiological diagnosis on the chest X-ray or CT scan. And the microbiological diagnosis on the detection of the microorganism either by gram stain or by the culture or by the serological test. So the main investigation in patients with pneumonia are: first, obtain radiological confirmation of the diagnosis, an X-ray or even CT scan, to exclude other conditions that mimic pneumonia. Then obtain microbiological diagnosis by the gram stain or by the culture or by the serological test. Then we assess the severity of pneumonia and we identify the development of complication. The investigation has been chest X-ray, CT scan, sputum examination for gram stain and for the culture of the sputum, or detection of the antigen in the urine or blood. And for the Legionella, we detect the Legionella antigen in the urine. A blood culture should be taken in patients with the suspected bacterial pneumonia. And blood culture only for the bacterial pneumonia. Not all the microorganisms can be cultured. Those who are cultured are mainly the typical microorganisms like the Staph aureus, Haemophilus influenza, Klebsiella, Pseudomonas, and Staphylococcus pneumonia. But the atypical microorganisms like the Mycoplasma, viral infection, and other are not cultured by routine culture. Serological test for detection of the antibody for atypical pneumonia and viral. Other tests may be done to assess the severity of pneumonia, like the arterial blood gas analysis, complete mixture to see if there is leukocytosis or leukopenia, and to check the renal function test, mainly the urea and creatinine. This for prognosis of the pneumonia. X-ray. The commonest X-ray finding, there is a shadow in the lung or homogeneous opacity in the affected loop, and may be lower or segmental. And this usually appear within the 12 to 18 hours from the onset of illness, and from a day to 3 days to 2 days from the onset of the illness. And first X-ray may be normal, this is not excluding the pneumonia, but later on the patient may develop the homogeneous opacity or consolidation, we call it also. In bronchopneumonia, there is patchy opacities in both lungs. And this opacity is not homogeneous opacity, it is non-homogeneous or hazy opacity in both lungs. Radiological examination is helpful for diagnosis and also is helpful for detecting the complications of pneumonia, like effusion, abscess, empyema, and other. Here you see the lung. Here there is non-homogeneous opacity, opaque consolidation affecting both lungs. This is typical bronchopneumonia, which is caused by either viral infection or by the atypical infection also. Here, there is homogeneous opacity in the upper lobe, and this is the transverse fissure. You see this homogeneous opacity, there is some area which is translucent in it. This is called air bronchogram. So this consolidation is present in the upper lobe. This is called right upper lobe consolidation of lower density, and it contains air bronchogram and not result in the not affecting the mediastinal thick, etc. So this is the right upper lobe consolidation. Also, this right upper lobe consolidation. This is the middle lobe consolidation. And here, if you see this thick cavity, this is a thick cavity, and there is air fluid level. This seen mainly in the lung abscess or in the head abscess. Mainly this is the lung abscess. As it appears here, so this is the thick wall cavity. It contains air fluid level. This is the fluidless air. This is the lung abscess. It's caused mainly by the anaerobic microorganism, by Staph aureus, or by Klebsiella or Pseudomonas. We come to the microbiological investigation. Patient usually has sputum. We take the sputum, which is the actual sputum, early morning sputum, and they send this sputum to the gram stain and the lethal stain if you suspect that this patient may have TB also. The gram stain divides the bacteria to the gram positive and gram negative. Gram positive will take the dye and appear as the blue color. Gram negative appear as the red color. The lethal stain is a special stain for the Mycobacterium tuberculosis and appear as acid-fast bacilli inside the lethal stain. So first we send the sputum for the gram stain or the stain. That's the second sputum culture, because sometimes the microorganism not detected by the sputum for the gram stain. We send it for the culture and sensitivity also. We do the sputum culture, and also in some cases we do the blood culture, especially with patients with pneumonia, with this usually develop septicemia, so the bacterium appear in the blood. So blood culture is frequently positive in pneumococcal pneumonia. So we do the sputum for direct smear by the gram stain, acid-fast bacilli, sputum culture, and also we do blood culture. For other microorganisms which are not detected by the culture or difficult for culture, we do the serology for them, which is acute and convalescent titer to diagnose Mycoplasma pneumoniae, chlamydia, legionella, and viral infection. So serological test for detecting antibody and antigen, usually it is used to detect the Mycoplasma pneumonia, chlamydia, legionella, and viral infection. Also, sometimes patients with pneumococcal pneumonia, the pneumococcal antigen may be detected in the serum and also in the urine. Pneumococcal antigen may be detected in the serum and in the urine. So any patient with pneumonia will have the period sputum or mucoperineal sputum. We take the sputum for the gram stain and for the culture and sensitivity. Those who has dry cough and the sputum was negative, we do for them serological test, detecting the antibody and antigen in the blood and also in the urine. Other test is the general blood test. And the patient will do complete blood count. There will be usually leukocytosis, neutrophilic leukocytosis, especially in patients with acute pneumonia. In the patient with pneumococcal pneumonia or other pneumonia, there is leukocytosis. The RBC may become more than 15,000 also, and sometimes become very high in severe pneumonia, or sometimes very severe pneumonia become low, develop leukopenia. So very high leukocytosis or leukopenia may be seen in the severe pneumonia. And also we'll check the serum creatinine and urea. We'll check the electrolyte and the liver function tests, because liver function tests are affected by the pneumonia, especially those with the atypical pneumonia. Later on to come after the diagnosing the pneumonia by the sputum culture and sputum smear, by the chest X-ray, CT scan, other pictures or other investigation. Later on we should know should have idea about the complication of the pneumonia. Because pneumonia is a very common disease, is acute illness, is emergency condition. If not treated, may develop the complication. The commonest complication of the lobar pneumonia, as I mentioned, because lobar pneumonia involving the pleura, it results in the pleurisy and pleural effusion. So the commonest complication is parapneumonic or post-pneumonic pleural effusion. And the effusion here is the exudate and respond to the antibiotic. Or there is empyema. Empyema, it means this fluid become purulent, develop pus, and we see pus inside the pleural cavity. Pneumothorax, especially occur with Staph aureus. In Staph aureus, the patient may develop cavitation or may develop nematocele, a cyst inside the lung, and this may rupture to result in the pneumothorax. Other severe pneumonia may to the suppressive pneumonia or to the lung abscess. Sometimes the bacteria may enter the bloodstream and result in the septicemia or bacteremia. So this infection may go to the joint, resulting in the septic arthritis. It go to the heart, infected endocarditis, and also may develop abscess inside the brain or may lead to the meningitis. Other complication, the patient may develop adult respiratory distress syndrome and bypass to the heart, to the respiratory failure, and even multi-organ failure. So the commonest complications which occur in the pneumonia are pleural effusion, empyema, pneumothorax, lung abscess, and septicemia or bacteremia may develop septic arthritis, osteomyelitis, cerebral abscess, meningitis, and the last one, patient with severe pneumonia develop adult respiratory distress syndrome and may pass to the respiratory failure and other organ failure like renal failure, heart failure, and others. So, patient when have opacity in the lung and there's consolidation or there's opacity in the lung, this mainly is the pneumonia, but should have other differential diagnosis. Like my patient may have this pneumonia, maybe this condition may be due to TB, especially if consolidation not resolved after the proper antibiotic. Or this mass may be, or this cause may be due to the lung tumor or lung cancer. Especially also when this pneumonia are not resolved with antibiotic, maybe due to TB or maybe to the lung cancer. Acute lung abscess. From the start may develop abscess, and also this may be misleading as pneumonia. Acute pulmonary embolism. Also the patient may develop opacity inside the lung. It's like consolidation, and this should be differentiated from pneumonia. It also can cause fever, chronic chest pain, and other systemic manifestation. Pulmonary edema, if it is not a problem, if it is unilateral, usually not caused by the heart, or called non-cardiac pulmonary edema, which can be unilateral or bilateral. Also, this may be mistaken for the pneumonia. And the last, there is the bronchus or malignancy, like bronchoalveolar carcinoma, which also may resembling the pneumonia. So the differential diagnosis pulmonary tuberculosis, lung cancer, lung abscess, pulmonary embolism. This is the most important one. Now, after the diagnosis, and we mentioned some of the complications of the pneumonia, and you go to the treatment or management of the community-acquired pneumonia. There are two types of treatment: the general treatment or support treatment and the specific treatment. Support treatment: the patient with pneumonia usually had fever, he needs rest, he needs antibiotic for the fever like paracetamol, he needs the good hydration also. If the patient has no vomiting, he can take the oral fluid or oral water. It's better to avoid smoking because this may exacerbate the infection or increase the infection. And if the patient has hypoxia, which will be checking the oxygen by the pulse oximetry. If the SiO2, the saturated oxygen, is less than 92, we give oxygen. The aim of the oxygen is to treat the hypoxia, to make the saturated oxygen more than 92 or the PO2 more than 60 millimeter mercury. So oxygen should be administered to the all patients with tachypnea, hypoxia, hypotension, or acidosis. And the aim of maintaining the PO2 of the more than 8 kilopascal or 60 millimeter mercury and saturated oxygen more than 92. This is about the supportive treatment. The most important is the specific treatment. Specific treatment, the patient needs antibiotic. This antibiotic may be given either orally or intravenously, parenterally, depending on the condition of the patient. We usually use the bactericidal drugs better. An antibiotic depends on the type of pneumonia and on the severity of pneumonia. But usually we take the sputum and send for culture, but we don't waiting the result of the culture because the pneumonia is acute emergency condition. If treatment are delayed, the patient may develop complication. So we start to give antibiotic before the result of the culture. And this depends on the clinical condition of the patient. Patient who has uncomplicated community-acquired pneumonia, uncomplicated, and it is mild to moderate pneumonia, the patient can be treated at home, usually, and this we can use the drug, this amoxicillin, 500 milligram 8 hourly orally, 500 milligram 3 times daily orally. This is the first drug we use, amoxicillin. If the patient is allergic to penicillin, because amoxicillin is of the penicillin group, if the patient is allergic to the penicillin, we use the clarithromycin, erythromycin or clarithromycin. Clarithromycin also given 500 milligrams twice daily, orally, or erythromycin 500 milligrams 6 hourly, orally. This for the uncomplicated mild to moderate pneumonia. We start by amoxicillin. If patient is allergic to it, we add to the clarithromycin or erythromycin. Patient if have severe community-acquired pneumonia, the patient are feverish, toxic, there is hypotension, there is hypoxia. So it means the patient has severe community-acquired pneumonia. Here the patient should be admitted to the hospital, and we start with the treatment by parenteral treatment. Usually, from the start, we give the co-amoxiclav intravenously. The dose usually is the 1200 milligram every 8 hours plus the clarithromycin 500 mg twice daily, usually given intravenous, or we give the third generation cephalosporin like ceftriaxone or cefotaxime intravenously plus the clarithromycin. Why we give with amoxicillin and ceftriaxone? Why we give the clarithromycin? Because before the result of the culture, we give it. Second, the patient may have infection with atypical pneumonia. Atypical pneumonia is caused by the mycoplasma pneumonia, by the chlamydia. This is not affected by the amoxicillin or amoxicillin and by the third generation cephalosporin like ceftriaxone. This needs the erythromycin or clarithromycin. So we give with the amoxicillin or with the ceftriaxone, we give the clarithromycin to cover also the gram-positive and other atypical microorganisms like the mycoplasma and chlamydia. As I mentioned, the commonest cause is either the Staphylococcus pneumoniae or the atypical pneumonia. So, comoxicillin with clarithromycin or the ceftriaxone with clarithromycin, they cover this antibiotic cover this microorganism. And this treatment of pneumonia usually from 7 to 14 days. From 7 to 14 days. But we wrote on condition. If the patient has more complicated pneumonia, patient with the pneumococcal pneumonia, 7 to 10 days we give it. But patient with the Staph aureus pneumonia, that treatment may extend to the 2 weeks or even 3 weeks. Patient with the Europe septicemia, Staph aureus bacterial septicemia, we give him for the 4 weeks. Patient with the Klebsiella pneumonia, Pseudomonas pneumonia, in which there is destruction of the lung parenchyma, the patient may treatment for the 6 weeks. So this depends on, but usually for the chronic acquired pneumonia, the treatment it is from the 7 to 10 days or 7 to 2 weeks, and 1 week to the 2 weeks. First, we start giving the proper antibiotic, and then we change it to the result of the culture and severity. Because sometimes in the pneumonia also we start by the other drug. We call it respiratory fluoroquinolone, like the moxifloxacin and the levofloxacin. This is called the respiratory fluoroquinolone. Ciprofloxacin is used mainly for the GI infection and for the UTI, not for the chest infection. For the chest infection, use the moxifloxacin and the levofloxacin. And when we give the treatment, we follow the patient. Most of the cases, clinical response occur in the matter of 2 to 3 days. The fever will subside. The patient general will become better. Appetite become better. Cough will decrease. And in the matter of 7 days, the patient may become very well. This for the clinical response. If the patient has no clinical response, it means either the patient may develop complication or the patient not receive proper antibiotic. For radiological response, we follow the patient for radiological response. At least we take the X-ray after the 3 weeks, because radiological resolution it needs at least 3 weeks. After 3 weeks, if there is no resolution of the opacity of the constellation, it means the patient develop this pneumonia is non-resolved pneumonia or delayed resolved pneumonia. So we repeat the diagnosis also. During the acute treatment, if the patient responds, we continue. But if the patient develops this feature, the patient may need admission to the intensive care unit. So these are indications for the intensive care unit, which include the following. First, failing to respond rapidly to initial management. And as mentioned, when we give the treatment, and in a matter of the 24 to 48, the patient not responding to treatment, he continued to have fever and continued to have cough and deterioration. This indicates the patient needs intensive care unit. If the patient has persistent hypoxia and oxygen concentration or PaO2 become less than 60 despite the high oxygen and antibiotic, or patient develop progressive hypercapnia. As I mentioned, pneumonia, acute pneumonia, usually may develop type 1 respiratory failure. There's hypoxia, hypocapnia, or non-capnia. But when patient develop progressive hypercapnia, it means this patient passed to the severe respiratory failure type 2. Or patient develops acidosis, shock state, and blood pressure become less than 90 or 60, become shock, or the level of the consciousness becomes disappeared and patient may pass with a confusion state or coma. These are indications for the admission to the intensive care and treatment in the intensive care unit. Not responding to the initial treatment, persistent hypoxia, progressive hypercapnia, acidosis, shock, and change in the consciousness, patient become confused or unconscious. We come to the prognosis of patient in community acquired pneumonia, which commonly caused by the pneumococcus. So pneumococcal pneumonia in a previously well individual has a mortality rate about 5%, and usually poor prognosis. So pneumococcal pneumonia usually carry poor prognosis, good prognosis, and the death rate is less than 5%. Prognosis become poorer, or there is poor prognostic point in elderly patient, more than 65-year-old. If patient has high CARE 65 score, يعني score about 4 to 5. High CARE 65 score, and patient may have a confusion, blood urea is high, respiratory rate more than 30, blood pressure is hypotensive. This may have more high CARE score. Also, this carry poor prognostic point. Very high or very low white BC count, which has severe leukocytosis or severe leukopenia. Also, this is a bad prognostic point. Absence of the fever. Patients who have not fever, usually this infection, pneumonia, can cause fever. But patient, if they do not develop fever, it means the patient is immunocompromised. So absence of fever indicates poor prognostic point. By X-ray, we did extensive X-ray shadowing. Shadow the lung involving more of the lung. Extensive X-ray shadowing also. Significant hypoxia. SpO2 or PaO2 less than 60 and continue to spike the oxygen and rise in the blood urea. All these are poor prognostic point in patient with pneumonia. Elderly patient, more than 65-year-old patient, high CARE score, very high or very low white BC, and severe leukocytosis or severe leukopenia, absence of fever, extensive X-ray shadowing, significant hypoxia, and rise in the blood urea. We finish the community acquired pneumonia from the pathology, pathogenesis, microorganisms causing it, clinical feature, diagnosis, investigation, complication, and management also with the prognosis. Then you go to the other term is nosocomial pneumonia. And it means pneumonia which occurs in the hospital. It has the same clinical feature and complication of the community acquired pneumonia, but more severe. Why? Because it's caused by the more serious microorganism. Nosocomial pneumonia or hospital-acquired pneumonia refer to the new episode of pneumonia occurring at least 2 days after admission to the hospital. A patient admitted to the hospital has no pneumonia, but for other diseases, for the hypertension, for the ischemic heart disease, for liver disease, and in the hospital, 2 days after admission, he developed pneumonia. This is called hospital-acquired pneumonia. And hospital-acquired pneumonia include the pneumonia occurring in the site, the surgical ward, medical ward, gynecological ward, or in the intensive care unit, or who patient was on ventilator, called ventilation-associated pneumonia. So nosocomial pneumonia or hospital-acquired pneumonia is referred to the acute episode or new episode of pneumonia occurring at least 2 days after admission to the hospital. The spread of this pneumonia transmission is different from the community-acquired pneumonia. The community-acquired pneumonia is droplet infection, airborne. Here there is microaspiration of contaminated oropharyngeal secretion seem to be the most common cause of the hospital-acquired pneumonia. So the mechanism of pneumonia or transmission is microaspiration of the contaminated oropharyngeal secretion. The most important distinction between the hospital-acquired pneumonia and community-acquired pneumonia is the difference in the pathogenic microorganism. Both of them in pneumonia, but the main difference between it is the different microorganism which causing the nosocomial pneumonia. So usually majority of the hospital-acquired pneumonia caused by gram-negative bacteria, Staph aureus, usually including Melissa. What means Melissa? Yeah, methicillin resistant Staph aureus. Methicillin resistant Staph aureus. So the microorganism which causing the nosocomial is very severe or more serious than community-acquired pneumonia. Usually gram-negative bacteria which is resistant to the antibiotic, and Staph aureus also, which is resistant to antibiotic. It's called Melissa, methicillin resistant Staph aureus. What are the types of the nosocomial pneumonia? These are, as I mentioned, nosocomial pneumonia. The first one is community-acquired pneumonia. I discussed it. But the type of nosocomial pneumonia include the healthcare associated pneumonia, yani patients who work in the healthcare and develop pneumonia. Hospital-acquired pneumonia, patients who are admitted to the hospital, to the medical ward, surgical ward, other intensive care unit acquired pneumonia, those in the intensive care unit, and those on the ventilation called ventilatory acquired pneumonia. So these are 4 types of the hospital-acquired pneumonia: healthcare associated pneumonia, hospital-acquired pneumonia, intensive care unit associated pneumonia, and ventilation associated pneumonia. The organism which causing nosocomial pneumonia, as I mentioned it, commonly are gram-negative bacteria like Klebsiella, Pseudomonas, and E. coli. And these usually are resistant to the usual antibiotic. Second, Staph aureus, including the Melissa, yani methicillin resistant Staph aureus. Also can be caused by Staphylococcus pneumonia and anaerobic microorganism, and also can be caused by the fungal infection. But the commonest one are the gram-negative and the Staph aureus. The third are the anaerobe. These microorganisms are more serious and lead to the serious pneumonia. and usually not responding to the usual antibiotic. About the clinical feature of hospital-acquired pneumonia, it is the same as the chronic pneumonia. Patients have very high fever, cough with hypoxia, cyanosis, tachycardia, tachypnea, and this more severe pneumonia. And the patient also might have cough with the presbytum or even with hemoptysis also. And usually patient may pass to the acute respiratory failure or may develop other complications also. The treatment, the investigation also the same. We take the sputum for the cultural sensitivity, but patient with nosocomial pneumonia is very ill. Sometimes he cannot cough and expurgate sputum. What we do bronchoscopy for him and we aspirate the secretion from the bronchi by bronchoscopy, and we send him to the gram stain and the cultural sensitivity. Because the patient sometimes is very tired, he cannot cough and expurgate sputum. We do for the bronchoscopy, we do for him bronchoalveolar lavage, and we wash the bronchi with the normal saline, and we take this secretion and we send it to the cultural sensitivity. Also by the chest X-ray and CT scan there is the pneumonia. And this patient usually needs blood gas analysis because usually it has acute respiratory failure. The treatment of the community-acquired pneumonia, of the nosocomial pneumonia, depends on the type of, usually starting by the very good antibiotic. Usually it's combination, depend on the culture, but we start by giving him moxifloxacin, levofloxacin, or we give the third generation cephalosporin or plus garamycin. So I don't go to the detail of the treatment because this we take it in the fourth year. But to have idea about it, the nosocomial pneumonia is a very serious, it needs very good antibiotic, and the treatment is more prolonged up to 1 month treatment. We come to the other pneumonia in the immunocompromised patient. And patient who has low immunity, his immunity are compromised, these patients are liable to pneumonia. Pulmonary infection is common in patients receiving immunosuppressive drug, and in those with disease which causing defect in the cellular or humoral immune mechanism. And the cause of the immunosuppression either defective phagocytic function, acute leukemia and lymphoma, other malignancy, solid malignancy, agranulocytosis, where there is loss of the white BC also, and cytotoxic chemotherapy, a drug which is given for the malignancy, and even all this leading to the, and also AIDS. All these AIDS, acquired immunodeficiency disease, also can lead to the immunosuppression. So the patient with this disease and other AIDS also, when they develop immunosuppression, are liable to develop the pneumonia. Pneumonia which caused, pneumonia in the immunocompromised patient, usually caused either by viruses, like cytomegalovirus, herpes virus, adenovirus, influenza virus, coronavirus also, or by fungi like the Aspergillus fumigatus, histoplasmosis, Candida albicans, and other, all caused by Pneumocystis carinii pneumonia, or called now Pneumocystis jirovecii pneumonia. I don't go detail in this, only to have idea about the pneumonia in the immunocompromised patient caused by this microorganism. And also this patient has the same symptom of pneumonia with the fever, cough, confusion state, and even may develop acute respiratory failure also. The other term of pneumonia is suppurative pneumonia, aspiration pneumonia and including the lung abscess also or pulmonary abscess. Suppurative pneumonia, from its term, the patient develop consolidation with the pus collection. Suppurative pneumonia is a term used to describe a form of the pneumonic consolidation in which there is destruction of the lung parenchyma by the inflammatory process, and multiple abscesses develop in this. Suppurative pneumonia is a term used to describe the form of the pneumonic consolidation, and this pneumonic consolidation is very severe, result in the destruction of the lung parenchyma by the inflammatory process. And also in such a case, there is multiple abscess formation or pus collection. The pulmonary abscess refers to the region in which there is large localized collection of pus and cavity formed by rupture into the bronchus. Pulmonary abscess is referred to the large localized collection of the pus inside the cavity. And this may be ruptured in the bronchus or sometimes may go to the bloodstream causing septicemia. So suppurative pneumonia, this is destructive pneumonia causing multiple abscess formation, and pulmonary abscess is a collection of the pus in the lung abscess or pulmonary abscess. Aspiration is defined as the inhalation of the oropharyngeal or gastric content into the larynx and lower respiratory tract. Aspiration usually occurs in patients who are unconscious or who are alcoholic or develop convulsion. During this period, he aspirated or inhaled the oropharyngeal secretion or gastric content may go inside the lung and sometimes lead to the chemical pneumonitis or may result in pneumonia also. The clinical features of suppurative pneumonia are the same as pneumonia, but usually it is more severe because there is pus collection. Patient has cough productive of large amount of the offensive sputum or foetid sputum, and sputum has very bad offensive odor. Cough productive of large amount of the purulent sputum, which is offensive in odor. There is pleural pain, productive chest pain. Sometimes there is sudden expectoration of the copious amount of the foul sputum occur if the abscess ruptured into the bronchus. When the abscess are ruptured in the bronchus, the patient cough a huge amount of the purulent offensive sputum, and the patient may be after that cured also. Or patient may have continuous intermittent pyrexia, and later also this may lead to this pus collection, may lead to the clubbing of the finger, which occur in the 10 to 14 days of patient. Treatment of the suppurative pneumonia or lung abscess also, we start by the antibiotic, postural drainage, physiotherapy of the patient. The antibiotic depends on the cultural sensitivity, and if not responding to the patient may need the surgical treatment. So I finish my lecture. Thank you. I hope that you are getting benefit of my lecture. I don't go in detail in pneumonia because pneumonia we give it in the 4 to 5 lecture for the 4th year. But for you as a second year, it's enough to have an idea about the type of pneumonia. Thank you.